Hello, I'm Nancy. I'm Professor Nancy Fontaine. I'm the Chief Nurse at the Norfolk and Norwich University Foundation Hospital. And we look enormous, and that must be how it feels. We have actually got 1,300 beds and we serve a population of nearly 1.2 million. We're a tertiary centre and we're a university hospital. And sometimes people think that that is often just too remote from our patients and our community. But actually we're all about listening to our patients and our carers and our families. So for families who are looking after people with dementia or even worrying about it, that might be a diagnosis, please don't worry, because actually we have a specialised dementia support team. We have also a patient experience team, and we have many specialist teams who are all trained to work with our patients with dementia across every single speciality. And that's really important for you to know, because sometimes it's not quite as easy. There might be a learning disability. There might be some challenging behaviour. You might be worried, and we can help you if we know about it. And I think the most important thing is that we co-design, we co-craft care plans and patient outcomes with you and the patient and the family. So if it's something you are thinking about coming into hospital, then we need to know about it early so that we can plan it. And that's what our specialist practitioners do. All the way through the hospital care, we want to make sure the patients and the families and the carers are co-partners in the decision making. Whether your loved one needs to go to theatre and there are areas of communication that we need to know, or whether or not you're worrying about discharge or next steps. These are areas that we're expert at. But of course, the most important thing is we need you, because you are the experts in the care of your loved one and your family member who has dementia.
I'm the Senior Matron for OPM, which is Older People's Medicine, which is the biggest directorate in the hospital. So we've got 5 wards which cover different specialities. We've got Elsing ward, which is our dementia specialist unit. We've then got Ersham, which is our orthogeriatrics ward, where we take patients who've got fractured neck or femurs. And we've got a short stay unit on Loddon, where patients who we think will be in sort of 3 to 5 days tend to go to. And then we've got 2 acute wards, which is Dunstan and Brundle, where patients tend to stay a little bit longer and sometimes have slightly more complex needs overall.
Elsing ward is our dedicated ward for patients with cognitive problems. It's part of the Older People's Medicine Directorate. So when a patient comes to us, they normally come through, if it's A&E, they will come through our Older People's ED department, which is known as OPED. And that environment was set out to take patients away from the normal ED pressures, so where they've got no windows, so time is hard to identify. So our Older People's ED department has a specialist room where we've got windows, and it's more like a ward for the patient, so it helps to keep them a little bit more settled, and at least they are aware of the time of the day, because obviously ED departments are busy 24/7. So the patients would go from there to the assessment unit, and the assessment unit would start to do some of the assessments with patients with dementia. And recognising those with dementia, we would put a blue wristband on them so that we know throughout their stay that they're a patient with dementia and may need extra support. When they are admitted to the ward, we'd put a blue dementia flower above the bed, and that helps with our catering staff and all the members of the MDT, and our volunteers as well who come in to help us will help to support those patients with dementia.
So we as a team offer additional support to people who are living with dementia as inpatients here in the hospital, and we also provide support to the family and carers.
In the mornings we have like a huddle, so we then allocate certain people to a certain dementia support worker. They generally stay with that support worker throughout their journey if they can, so that person will then build up that rapport with them, the trust and obviously the familiarity as well.
The first thing we do as a team is we find out more information about the person that's living with dementia. So we'll complete a This Is Me booklet. So it's all about the person, about their likes and dislikes, their preferences, and it just really helps us provide that person-centred care while they're here in hospital with us. With that information, the dementia support team will plan activities around their interests, things that they like to do. It might be looking at pictures of something that's relevant to them, listening to music.
We really like engaging our patients with our iPads. We do use them as a bit of a lifeline sometimes, so what can be really helpful is if we don't know the person at all until we've met them obviously for the first time, sometimes we meet them before we have the information from the This Is Me. So when we're having that first meeting with somebody, we don't know what they might say or what we might find out, so then we can use them to use the iPads to bring up any picture that comes, any topic that comes up in conversation.
It might be supporting them through an intervention of some kind as well, like a blood test, supporting them to feel calm during that. The nurses in the team, we might be doing nursing assessments to look at why someone might be demonstrating particular actions. So they might be quite distressed on the ward, they might not be eating and drinking very well. So we'll do a nursing assessment to look into why that might be happening, and then see how we can support them during their admission.
It's everything. It's got everything in there for everybody, all parts of the medical staff. There's mobility, there's communication, there's medication, there's obviously things for us when we do.
Our team is relatively small for the size of the hospital, so it means that not everybody with dementia will be supported by our team. But if you've got a This Is Me booklet, then that supports the person-centred care on the ward.
We also like to invite carers and relatives into the hospital to help with their loved ones throughout meal times. If there's something that they're used to doing sort of day to day, it could be that the relative or the carer would like to continue that, or the actual patient themselves would like that as well. So we do have a carer's passport which will enable them to come in generally throughout any time of the visiting times, or before or after, just to include for those meal times at lunchtime and evenings.
They can ask at the reception desk for the carer's passport, so that is a little leaflet that will be given to them with the information.
That can be used to support the person through, it might be emotional support, it might be to help them with eating and drinking, it could be for them to help take their medication.
And they will also be given a little card with contact details on, which they can use, and they get free parking, they get discounted meals and refreshments in the canteen, so it's really useful to be able to get one.
It's just really important that that person has their advocate there with them. So it's something that we are trying to promote on the wards. I think it's really important that people are aware that it exists. So if it's something that you think that your family member or care or someone would benefit from, then you should ask the ward staff and they'll be able to help you with it.
Sometimes when visitors come to visit their loved one with dementia, when they leave, that can really make that patient be unsettled, and sometimes being in this environment, it may not be a good thing for them to spend a long time because of when they have to leave.
First, if we get referral through, one of the first things we'll do is look up prior information that we've got on our system. So that would be prior episodes of care or care planning or information, which would be really helpful, not just for us but for the ward as well, because often they can't get hold of loved ones, or if loved ones are ill, or if they haven't got someone or carers to give them that information. So we would make sure that we've got information about the individual, their care needs, their own symptoms. We can then help the ward to plan alongside working with any physical symptoms they've got as well, to actually minimise distress. If the ward specifically refer people to us that would need some more support and understanding and even knowledge of prior situations, and if they're definitely referred to us, that we would make sure we would support the ward with that care plan and onwards care.
When a patient gets into the hospital system, if they're then going to need care or a care home for discharge, that wait can be quite a long time. So from when they're medically fit, and if anybody can support their relative out of hospital to await the care home or care providers, I would advise it's better for the patient, because they get back to their home environment and are less confused than perhaps they are when they're with us as patients.
And we do a lot of carer support as well, because it's quite a challenging time for people that are coming into hospital. It might be that you're giving up that caring role a little bit, and that might be a bit more of a challenge.
I think for carers it's really difficult, because often carers will forget their own care needs and they become quite upset, frightened, frustrated. And I appreciate the hospital's very dizzy, difficult place to get through to at times. So I said to carers, make sure you look after yourself. Please, please, please make sure you look after your own mental well-being as well. You need to speak to us. You know, part of the role that we do is we certainly involve, we will telephone, we will do everything we can to get through to carers and family as well. Sometimes if they encourage them to have a day, not to visit, or if they feel they need to come, we'll try and support that visit as well. Anything they feel else we can do to help, we're literally open to any suggestions.
It's a real privilege to care for the elderly because their stories are fascinating, and you never fail to be amazed by what people have done historically, what's happened to them as individuals, their families, their journey. So it's a real privilege and it's a really interesting speciality to work in.
As we know, it can be very frightening coming into hospital, so to the thoughts of having an operation as well is really quite scary. So it's important that we prepare for patients coming into theatre, especially those with a dementia diagnosis, which can present its sort of challenges as well. The dementia will have been discussed with the patient's consultant and the pre-op staff, and they will encourage the patient and their family to complete the This Is Me booklet.
We don't necessarily get told, people who have dementia, we get a list of patients who have been seen in clinic that day. The notes then arrive, and because we've gone from the big notes to smaller notes now, we don't get as much information. So we do rely on people to sort of inform us.
The patient themselves will have a blue wristband on, which you will see on the wards as well. That just again is that identification of the dementia diagnosis.
It's quite important with someone who's got dementia that they bring someone with them to the appointment, because they may be asked to be examined for urology, breast, any of the specialities really, and some of the tests are done while they're here in an outpatient setting as well. For us being strangers to the patient, it may be quite daunting what they've got to have done anyway, but I think it's very important they have someone with them that they can trust and that can help advocate for them and let us know, if the patient feels comfortable or not.
We are very fortunate. We have an older person's emergency department here, which is the only one in the UK. They see all our over 80s patients, so patients will come in via ambulance, for example, start off in our rapid assessment treatment area, and then they'd move through to our majors cubicles, where they'd have a team of nurses looking after them, and a plan of care would have been made by that point. For those patients under 80 that wouldn't qualify to go to our older person's ED, they would arrive by ambulance or by foot, and then they'd be assessed by a senior nurse. And we will then take bloods, ECGs, observations, and would start that process of being seen as a patient in the ED. Because our dementia patients are often quite at high risk of falls, we operate a bright yellow blanket and non-slip socks. So those patients are easily identified by the nursing team.
We work 24 hours a day, and our patients come through on an emergency booking system. We will contact the ward prior to the patient coming to theatre, and we like to get some information to make sure the patient's happy. If we have a relative or a carer with the patient, they're welcome to come into the anaesthetic room with them. When they come into the anaesthetic room, it's quite a different environment. It is quite bright. If people are feeling upset, we can sometimes reduce the lighting, and also just get down to the patient's level and sit and talk to them instead of standing over them. We do like to put some monitoring on the patient. We put the blood pressure cuff on. This can go quite tight on the patient's arm, but we reassure them that it doesn't last for long and it will go down. There are quite a lot of clinical noises in this room, but we can reduce those noises to 0 and put them on mute.
Once the operation is finished, the patients are transferred from the operating theatre to here in recovery, and because we are aware that the patient has a dementia diagnosis, we are able to provide a more quiet space. So we come round to this side of the room, for example, and we put all the monitoring on from the equipment here, which is the same that would have been used in the anaesthetic room and in theatre.
When people are waking up from anaesthetic, it can be quite confusing when you first go from being deeply asleep to being awake, and it's a different environment. Having someone who knows what someone's personal needs are and how to communicate with them, because everybody's different, it really makes a difference to keep people calm and to ease them back into the kind of being awake again.
Patients can feel confused and a little bit agitated, so sometimes just having a distraction can really help. Obviously the hand holding, using a calm voice really helps, and having that relative or carer with them is perfect, but we do have these activities here as well. Obviously it's dependent on how long the patient is in the room. There might not be time to do all of them, but we let the patient choose what they would like best. When that time is up, the patient would all the monitoring be taken off and they'd then be escorted back to the ward, at which point the relative or carer who's been with them throughout would be walking alongside the bed all the way back to the ward, and we would then hand over the care to the ward nurses.
Some patients require hospital transport, which is booked from outside of our service. It's booked either via the GP or the care home or somewhere they come from. So it'd be really useful for them to book a wait and return journey where the patient can be brought in, that crew then wait for a period of time. We can get that patient seen so that it's done a lot quicker, and then that patient has got their transport ready to take them back home. Whereas if it's not booked as a wait and return, they can be waiting for up to 3 hours to then get taken back.
It's been wonderful to have had this opportunity to share the things we've been doing for patients who are living with dementia, and I'm very proud to be a nurse, very proud of my team, and we never stop learning, and we're always looking for new ways to support patients.
So we work so closely with all of the wards. Everywhere we go, we meet lots of different people, lots of different specialities. It's really important that everyone works together to support the person living with dementia.
So I think across all the wards we've got a really good sort of multidisciplinary teamwork. So we work with lots of different professionals, occupational therapists, doctors, physios, speech and language therapy, dementia support workers, and that probably doesn't cover nearly everybody by any stretch. So there's lots of different specialist teams that we work with to provide really holistic care for patients with dementia.
You could find us in women's health, or in paediatrics, or in older person's medicine, in stroke, and in the front door, like in the emergency department and A&E as well. So we're kind of a support service that go across the whole hospital.
As a team, we care for patients, families, as well as staff in the hospital, and we do this in a range of ways.
Bailey is a pets therapy dog. She's one of a group of 3, but she comes in and we come in twice a week. We go wherever the doctors ask us to go to visit particular patients.
So we often see patients with dementia, and sometimes they can have problems with swallowing, so difficulties with eating and drinking, and sometimes food and drink can go down the wrong way, so it can go down into the lungs, which can cause chest infections. So we can assess the patients and give recommendations about food and drink that are different textures, so we can support with that.
Our role would be around looking to improve or helping them to regain independence and function and movement after illness or injury, and that could be by looking at their movement and their strength and their ability to get up and move around and what help they need with that, and focusing on trying to improve that for them.
People like to come down here and be still because it's different to the rest of the hospital. There's no bleeps or noises or cluttering, and as chaplains we want to support them. We've got the kettle always on, so we're happy to make them a cup of tea, to sit and chat, to support. And also, if we can help as being an intermediary between them and staff, if they've got things they don't understand or things that are going on, we can work with that.
Bailey does whatever is asked of Bailey, so we've done very happy times, we've shed a few tears, we have a little chat. So sometimes we walk into a ward and nobody's talking, and we arrive, and before you know it, everybody's talking to each other. Makes everybody smile, brightens up the day. Has been known to give people very lovely cuddles when they need a cuddle.
It's very rewarding to help people, and like support family and carers when they come into hospital and give them advice, so when they are discharged then they've got more skills and strategies to help that patient.
We have to obviously take into account that they're finding the hospital environment very unfamiliar and quite distressing.
If you have a chaplain at your bedside, which is quite a confusing time, you've got different health professionals coming around, and you think, at the best of times you're thinking, who are you and what are you doing at our bedside? So as chaplains, we try and introduce ourselves, get to know a little bit about the person, a little bit about their life, and help them to reflect on their journey.
We often ask the relatives to complete a "This is me," which is very helpful because it helps
us as OTs and all my health professional colleagues.
It's really useful to just know as much about that person as possible and to know what's usual for them in terms of their ability to get up, to move around, what's their background, you know, have they had lots of falls at home before, or what does the carer have to do to support them in their day-to-day life.
We often liaise with family members and carers, and we often give them a phone call and ask what difficulties the person's been having at home. So if they've been having any swallowing difficulties at home, we can find that out. And same with communication difficulties, and then we can kind of get a bit more understanding, so when they're in hospital we can support them and know a bit more about them and help them, and I give more advice on discharge as well to family members.
So my name's Claire, I am Senior Discharge Matron for the Norfolk and Norwich. I sit over the IDT, the Integrated Discharge Team.
I support patients who are living with dementia at end of life and also supporting to manage their symptom control needs with the support of the inpatient teams in the hospital.
Discharge has changed hugely since COVID. We now do something called Discharge to Assess. The idea is we don't make any long-term decisions from hospital. Those decisions are made out of hospital in a more suitable environment. We are home first. Anybody we can get home, we want to get home. We know that's the right thing to do. Sadly, unfortunately, we're not always able to support that. There are real challenges in the social care market currently. There are challenges within discharge care homes, lots and lots of different reasons. But we are working really hard to work with you to put the patient first and to get patients discharged. Currently we support Discharge to Assess. This supports three main pathways. We have our D2A zeros. These are patients who are discharged with nothing. They come in, we make them better, they go home. Pathway 2 is our reablement pathway. It's home with a package of care and or therapy support. Pathway 2 is for patients that sadly can't return home because it's not safe for them to do so. These patients will need to go into a bedded solution. Pathway 3 is our more complex patients. These are our nursing home patients.
We are referred by the teams within the inpatient wards, and I offer holistic assessments to patients who perhaps have uncontrolled symptoms. So this might be around pain, nausea and vomiting, shortness of breath, and being unsettled, agitated, for example. Usually, typically in the morning, I will look at the patients that have been referred to the team. I will then prioritise those, and I will then go and see those patients on the ward and spend some time with them. I will sit with them, make assessments, observe them. I would look and see whether they are in pain, because many of these patients are non-verbal. So again, sometimes it's very difficult to recognise if someone is in pain. Also, as well as supporting the nursing teams on the ward, the medical team making recommendations for medication purposes, and also supporting patients to their preferred place of care and where they would like to be for their future ongoing needs.
Obviously, many of our patients are elderly, are more complex discharges, so obviously a lot of patients, especially patients on pathway 2, that are unable to go home because they're not safe to be left between care calls, so they require a bedded option. Obviously we work really closely with carers, patients, next of kin, to try and explain discharge. Discharge is really complicated, so it's really trying to work collaboratively with the dementia support teams, with the patient, keeping the patient the centre of all conversations, and carers wrap through this really challenging time.
Anyone living with dementia, it's really important to know them and what's important to them, and having forward-thinking plans around maybe advanced care planning. So often what we know and what we see within the hospital setting is we don't always know where that person wants to be cared for at the end of life.
So it would be really, really crucial to liaise with their relatives, that person as well, including them in decision making, and finding out what's important to them, what do they like, what music, what TV programmes, all those kind of things, to make it really important and personal, holistic for that person. I would also perhaps pick up the phone to relatives, because they could be quite distressed, they might not really understand what's going on. So really taking the time out and liaising, talking, reassuring, and offering them some psychological support around what's going on with their loved one.
We know that discharge is complicated, and we know that this is a really, really difficult time for everybody. Please, if you don't feel that you're being informed, you don't feel that you know what's going on, please ask to speak to us. You know, the wards are very busy, the staff are very busy, but we are happy to help. We may not be visible on the ward, but if you speak to the coordinator, someone will contact us and we will come and speak to you and explain things to you. We do want to help, and we do understand.
I'm really proud of the work that Liz Yaxley and Jenny and the whole of the dementia support team have done here, because actually we've worked with patients and families for many, many years, and we have crafted a model that really works for our community. So please don't hold back in coming forward and asking us if you need some help or if you have any questions. We look forward to seeing you here, because we may be a large unwielding hospital, but we are your local hospital, and we're here for you and the community.
Thank you for watching. If you would like more information, please visit norfolk-and-suffolk-caresupport.co.uk, where you'll find further training on our learning portal. The link for this website is in the description down below.